Okay, so I have here evaluation and management service flow chart. This should help you utilize. It's actually on the Blackboard under coding tips. You have evaluation and management, so we have not only the E&M tables, but also calculating the history. Because there are some certain things that you need to do when you're actually calculating the evaluation and management. So this should help you as far as should I be looking at key elements? Should I be looking at time? What's included in those key elements? What documentation do I need? So there are several sheets to this particular evaluation management service flow chart. The first thing is we're going to determine location. Do we need location? As far as our location goes, are we using key components? Are we using time to determine our level? So what I did was here, I listed what's time service locations versus the service locations that require key components. So the ones that are office or other outpatient services such as urgent care, observation care, observation subsequent hospital care, OBS inpatient admit discharge, consultations, emergency department, nursing facilities, domiciliaries, rest homes, and home services. Those are going to require your key components. And when you're flipping through there, you have your history, you have your exam, and you have your medical decision making. So that's the first one we have. The others are hospital discharge, other emergency department services such as en route to like ambulance services, nursing facility discharges, prolonged services, standby services, transitional care. Okay, and under that, time is a major component for these categories. So we see that. So you're going to review the category specific for times. On the ones that require key components, we're looking at, is the patient a new patient, meaning they've been seen, they haven't been seen in the last 3 years by that provider or someone within the same subspecialty or group. Are they established? So if they're new, we need 3 of 3. If they're established, we need 2 of 3. So our key components here are history, examination, medical decision making. So you're going to continue on with those. So our first key component is going to be our HPI, which is our history of present illness. So on this particular one, we've got what's included here is we have location, quality, severity, timing, context, modifying factors, associated signs and symptoms. The location, where is it located? The quality describes it. Severity, we rate it. Timing is when did it start? Context, what are you doing when it occurs? Modifying factors, what makes it better or worse? Associated signs and symptoms, so what else is occurring at the same time? And notice that what you don't want, the MD, the medical doctor should not use patient here for follow-up. Specific reason must be clearly stated. So an example we have here is the patient's cough is non-productive and non-barky and has worsened today. Patient also has rhinorrhea, which began yesterday. So when we're looking through that and determining what elements, we have location as chest because the chest is where the cough is going to come from. Quality is non-productive, so there's no sputum being produced. We have context and we have modifying factors. So non-barky and it has worsened, or you can put it under modifying factors, meaning it's worsened. But you can only count it one time. So if you count it for one, you can't count it for the other. And then we have associated signs and symptoms as rhinorrhea. Example, so we would have 4 elements out of the HPI, which would be comprehensive or complete. Example 2, the 15-year-old male is doing very well on his insulin regimen. His insulin does remain low, 29N plus 1R in the morning and 6N at night. I note that he is having few lows in the middle of the night, even though he cut back on his insulin at night to positive 4N on game days. This has been an issue. Even though he eats well, he goes low at night because of the activity level. So the things we have here is we have quality, because there's few lows in the middle of the night. We have timing. He's cut back on insulin at night and on game days. Context, insulin does remain low. And modifying factors, even though he eats well, he goes low at night because of activity level. So although we have more information, we still only have 4 key elements. Okay, the note here is E&M guidelines allows documentation of the status of 3 or more chronic conditions. So it's acceptable for extended HPI. The example we have for that is patient presents for follow-up for hypertension, diabetes 1, and COPD. Hypertension, blood pressure is elevated to 160 over 100. Diabetes is good blood sugar control, and COPD is stable. So that would be the documentation for those chronic conditions. ROS is review of systems. So problem pertinent is one system directly related to the problem that they presented with. Extended is 2 to 9 systems directly related to the problem in the HPI and a limited number of additional systems. And then comprehensive, they're going to look at 10 plus systems directly related to the problem in the HPI plus all body systems. So some of the things that you're looking at for the review of system, and again, this is going to be subjective, is from the patient's point of view. Constitutional, we're looking at fever, weight loss, and vitals. You need 3 of those, 3 of the 7, which is BP, temp, pulse, and regularity, height, weight, respiration. General appearance, development, nutrition, body habitus, deformities, attention to grooming. So one of those would be constitutional. Eyes are looking at maybe double vision, pain or eye strain, ears, nose, mouth, and throat, pain, sinus drainage, pain with swallowing. Cardiovascular, you might see chest pain, edema, palpitations, because edema is going to impact the blood flow, is going to impact swelling. Respiratory, you may see shortness of breath, wheezing or dyspnea. Gastrointestinal, bowel movements, appetite, bloating, stomach pain. Urinary, burning when urinating, discharge, hematuria. Musculoskeletal, we're looking at pain, stiffness, or swelling. Integumentary, you're looking at skin and or breast, which is pain, itching, rash, bleeding. Neurological, we have seizures, headaches, tremors. Psychiatric, you're looking at sleeping habits, awareness, feelings. Endocrine, thyroid problems, excessive thirst or sweating. Hematological or lymphatic, bleeding, bruising, which is non-traumatic, anemia. And allergic or immunologic, allergies, reactions, immune symptoms, problems. The note here is we do not count elements previously counted and used in the HPI. So if we don't have anything listed in our review of systems, we can't pull elements that we've already previously used. However, if we have additional information such as they had rhinorrhea and a headache, and we didn't need to count that, we only needed to count 1 for the signs or symptoms, we could use headache down below, or even rhinorrhea for the ears, nose, and throat. If an element was used in the HPI, it cannot be used again in ROS. Using an element for both the HPI and ROS is called double dipping. So that is a term that you would need to know. Okay, so we have some examples. Example 1, mother denies any diarrhea or other GI complaints. Patient's sleep pattern was poor last night and appetite was down today. Patient is positive for fever, cough with trouble breathing at night. So for symptoms reviewed, we have GI because we have diarrhea and appetite is down. We have neuro because the sleep patterns are poor. Respiratory is cough, and constitution as patient is positive for fevers. Example 2, review of system from 4 months previously reveals that he is doing well. He has experienced no GI or GU symptoms, no neurological complaints. He has minor joint aches following extensive practices or games, and his mood and affect are good. So we have GI, no complaints. Psychiatric, mood and affect. Neurological, no complaints. GU, no complaints. In MS, or musculoskeletal, we have joint aches. So we have 5 systems here is an extended ROS because it's, again, between 2 and 9. Example 3, negative for cough, palpitations, dizziness, has chest pressure, occasional constipation. The remainder of the reviews of system is negative. So this is actually comprehensive. The reason for that is they actually did review 2 or more other symptoms. So our cardiovascular system is palpitation and chest pressure. GI is occasional constipation. Neuro is dizziness. Remainder of systems is negative, which would make that complete. And we also have respiratory, which is cough. So the note here is a complete review of system inquiries about the systems directly related to the problems identified in the HPI plus all additional minimum 10 organ systems. Those systems with positive or negative pertinent responses must be individually documented. For the remaining systems, a notation indicating all other systems are negative is permissible. And in absence of such notation, at least 10 systems must be individually documented. So either you're going to see that checked or you're going to see a statement. FISH, our past family social history. So on this, for new, requires 3 elements. Established requires 2. Pertinent is 1. And again, depending on the location, will change the new and established. Such as emergency department only requires 2 of the 3 to be complete, whereas urgent care and office visits require 3. So that would be a difference. So you just make sure you review the stipulations for each location. So our history is past is the patient's past experience with illness, operation, injuries, and treatment. Family is medical events in the patient's family, including diseases which may be hereditary or place the patient at risk. Social is age-appropriate review of past current activities, drugs, smoking, drinking, caffeine, exercise, occupation, divorced, married, loss of a loved one. Example 1, patient finished Keflex for cellulitis 1 week ago and was doing well. Mother has given patient Tylenol and Robitussin for a cough. Patient has a history of reactive airway disease, and mother ran out of albuterol 1 to 2 weeks ago, but states that she didn't believe it helped. Patient has history of upper respiratory infection, symptoms on and off for the past 3 months. History reviewed, we have past medical is past illness, cellulitis, Tylenol and Robitussin given for cough, and patient has a history of RAD. And URI symptoms on and off for the past 3 months. There's 1 history pertinent, so we have past history. Example 2, FISH remains unchanged from history from date 12/6/2000. See the form, patient intake form reviewed, medical, family, and social, at least one element per each. So on that, they reviewed it. When the history was reviewed, the past problems, ear, stomach, heart, high blood pressure, immunizations were up to date. Family, mother had thyroid, father has hypertension and diabetes. And social, caffeine, yes, tobacco, no. Occupation is a bank examiner. So there are 3 histories. Okay, so the next thing that you have to determine is you take that history, each one of those elements, and you determine what is the appropriate level. So is it new or established? So from that, we're going to look. So as you can see, items furthest to the left determines the history. So if we do not have, if we have not met all 3 within there, we have to go to the furthest to the left to determine history. So for example, if we have a brief HPI, a problem pertinent review of systems, and a pertinent fish, we would have to give it problem focus because we go all the way to the left to determine that. Established is the same. So it would still be problem focused would be our history. And then we see here expanded problem because we had a brief HPI, a problem pertinent review of systems, and a none under the fish. So that would have been expanded problem focus. PE, our exam, it's either done in body areas or organ systems. So a head including face, neck, chest including breast and axilla, abdomen, genitalia, groin, buttocks, back, and each extremity. Then organ systems, we have eyes, ears, nose, mouth, and throat, gastrointestinal, musculoskeletal, neurological, hematologic, lymphatic, and immunologic, cardiovascular, respiratory, genitourinary, skin, and psychiatric. This is going to be what is objective. The doctor physically reviews what's given. So problem focused here. We have one system or body area. Expanded problem is going to be 2 to 4 systems. Some carriers recognize 2 to 7 and or other body areas. Detailed extended exam is affected body areas or body systems and any other symptomatic body areas or related organ systems. 5 to 7 systems and or body. Some carriers is 2 to 7. So again, carrier determines. And then comprehensive 8 or more. So the reason for these differences is actually to further clarify which do you normally fit in, because 2 to 7 you could actually go with a level 3 over a level 4 because of the fish or the PE, excuse me. Note, according to the 95 documentation guidelines, the extent of the examination performed and documented is dependent upon the clinical judgment and nature of the presenting problem. So specific, abnormal, relevant, negative findings on the exam of the affected or symptomatic body areas or organ systems should be documented. Notation of abnormal without elaboration is inefficient. So they can't just put abnormal. They have to tell us specifics. Abnormal or unexpected findings of the exam of the affected or asymptomatic body areas, organ systems should be described. A brief statement or notation indicating negative or normal is sufficient to document normal findings related to unaffected areas. So again, if it's abnormal or we have unexpected findings, we need those documented very specifically to count. MDM, it's got 3 areas. It's got the number of diagnosis and or treatment options, amount and or complexity of the data and risk of complication, morbidity, and mortality. And then determining the level, we're going to take our history, we're going to take our exam, and we're going to take our MDM for each one of those. Our history is going to be expanded, examination expanded, MDM is low, new patient requires 3 of 3. So then that would give us it. Established, again, we would have the same, but it would be detailed because we have 2 of the 3. So that's what it means. When it's been highlighted on the history, it had a comprehensive history. The exam had a detailed examination. MDM had a low. All 3 of these had been met for the 3 of 3, whereas we have the exact same thing, but it's expanded. So we had comprehensive, we had detailed. So because detailed and detailed, they're both highlighted, still low, but we have 2 of the 3. So again, it would follow as moderate level. Okay. There is a blank form for determining the history level on Blackboard for you, as well as the E&M tables. So this is, there's 5 levels of services. So we have outpatient and emergency room, we have inpatient, nursing facility, as well as domiciliary, rest homes, and or custodial care and home care. So on these, we can see for the top, outpatient and emergency, we have new office, and ER falls under new because we need 3. We don't have an established in the emergency department. So new office and or urgent care, we have established office requires 2 of the components. So new is blue, orange is established, so you need 2 of the 3. So when you are determining what you're going to select, we have ER, problem-focused ER EPF, ER EPF, ER detailed, ER comprehensive. Same thing with examination, ER, and then medical decision making. And so under that, that's the average time they would give you the visit. So again, we need 3. So you could do comprehensive, you could do detailed, you could do moderate, and we would need 3 out of 3 because we have detailed in the examination. If it is an office, a new office, it would be 99,203. If it was the emergency department, it would be 99,283. The same thing over here. We have minimal, which is 99,211. That's really, there's nothing there. Problem focus, 99,212. So that's going to do it. The same thing with our inpatient. So after you determine where is the location and the service type, such as office and or emergency department, is it new or established, then you would select from here. Okay, so those are the forms and how you utilize those forms as far as the E&M. It should go along with Cengage and the information you're learning in there. Keep in mind that for the certification exam, you are going to look at case studies, and actually I believe there's about 5 of them, but you're going to have to determine the level. And it is multiple choice, but the thing that you can get confused on is the location of what you're looking at, as well as is it new or established. So those are the things you're going to want to pay close attention to. You can do by process of elimination by making sure that the evaluation and management codes that are for the wrong location, you go ahead and mark those out and then review the information. Is it new or is it established? So from there, then you would select the right visit based on that. But you're still going to have to utilize tools to calculate the visit, because they don't all provide all the elements. You're going to have to utilize your tool to determine what was the level of HPI, what was the level of exam. So you may have to do that, as well as medical decision making.